everyone who was able to join us and those of you who might be joining in on our recorded session. We are here today to talk about the results of our CMS Innovations Challenge project. Our project ended on August 31st. However, because of the time that it takes for claims to adjudicate, we thought that the end of the calendar year was actually the ideal time to report our results to you. It gives us a bird's eye view, and it gives us an opportunity to thank all of you for those really wonderful supports and partners that we had throughout this year. We learned a lot, and we had to really stretch, and a lot of you helped us do that. So thank you, thank you, thank you. We wanted just to take the opportunity throughout this discussion to let you know where you had some really important impact on the project. Next slide, please. So what we'll talk about today are what were the goals of the project, a little bit of history, how was the design, and how did that design change during the project year. We really enjoy talking about what we learned and how we innovated. After all, the name of the project was Innovations Challenge, and so we were really excited about some of the twists and turns that happened during the year. What were our results? Did we achieve what we said we were going to achieve? And what would we do next time if we were afforded the opportunity to do some more on this project? And then you'll hear throughout the discussion an opportunity to thank you, our partners, because you all definitely, in ways you can't even imagine, helped us achieve what we would think, what we hope to demonstrate is a lot of success. Next slide. So a little just historical perspective. So in November of 2019, the Centers for Medicare and Medicaid Services, otherwise known as CMS, in its wisdom issued a challenge, otherwise known as the challenge, to Medicare Administrative Contractors, or MACs, of which WPS is one, to identify underserved populations and underutilized services in their jurisdictions and figure out a way to remedy some of those deficits. Depression was an under-recognized chronic illness, and WPS investigated this first as a potential response to this challenge. They were accepted for proposal in 2020 and 2021. And then for project year 2022, CMS again extended the challenge, and they wanted us to focus on high needs beneficiary groups. 7 Medicare administrative contractors applied, 19 proposals between the 7 were submitted, 6 were selected, and even though WPS is not the largest MAC, we had 2. Both of our submitted proposals for depression screening and chronic care management were accepted. Next slide. So the project year began in September of 2022. It focused on those underutilized Medicare programs for depression screening and chronic care management in J5, which includes Iowa, Kansas, Missouri, Nebraska, and J8, Indiana, and Michigan. And this had a special emphasis on health equity. That is often a challenge for MACs, but particularly trying to define what that health equity and health disparity, how we're going to figure that out. We utilized something called the Area Deprivation Index, and I want to tell you a lot about that. Next slide. So you can see on this heat map various areas throughout our jurisdictions, and it might be hard to discern at this level. However, you can imagine fairly easily that red is not a good place to be. It puts you in the 10th decile, or otherwise known as the most disadvantaged neighborhoods. And I want to tell you a little bit about this, but I'm also going to encourage you on the next slide, Mary, to see where your community falls. This QR code will take you directly to the neighborhood atlas where the area deprivation index is housed. It's based on a measure created by Health Resources and Services Administration, or HRSA, over 3 decades ago, but it's been refined, adapted, and validated. One of the best things about it, working for Wisconsin Physician Services, that it actually was developed at the University of Wisconsin-Madison by Dr. Amy Kind. This allows for rankings of socioeconomic disadvantages in a region of interest, and it uses domains of income, education, employment, housing quality to determine where a neighborhood falls. I did this for my own neighborhood, and it's really interesting. Living at the moment on the west coast of Florida, those along the coastlines, as you can well imagine, they're in blue. They are pretty well resourced, and I could almost tell you exactly where some of those red areas were, and I was amazed at just the distinction and how accurate it was. I would encourage you all to take a look at this and just play with it a little bit and see where your own community falls. While you take a look at that, I'm going to introduce my colleague from Provider Outreach and Education, Mary Muco, who's going to share with you what the project design looked like at its inception. Mary?
Thanks, Joelle. Good evening, everyone. I'm Mary in Provider Outreach and Education, and I want to show you a couple of slides that really show the initiatives involved in our efforts. We started the Depression Screening Challenge actually 2 years before Joelle came on board, and this slide actually shows those efforts or the methods we employed in the first 2 years of our Depression Screening Challenge. And use of these efforts indeed proved successful, and we continued these into year 3. If you look to the left side of this slide, you will see collaboration and partnerships at the top. And this helped us reach more allies, those folks that were poised and ready to help us reach our goal. Outreach and education is in the center, and this took many forms, and feedback from our learners actually helped share our education as we moved forward. It gave us great ideas. All of the efforts that all of the providers that participated in all of these events were just tremendous. And finally, on the right-hand side of this slide is data and analytics. And this, of course, was instrumental in helping us determine where to focus our efforts and then to provide information out to providers, such as in comparative billing reports, which would let a provider see his or her use of depression screening compared to that of his or her peers. This slide then represents the new initiatives that we employed in year 3. Our partnering efforts took on a new look as we started reaching out to those underrepresented groups that Joelle talked about. Outreach and education actually took a new path, and while we ended up taking some new turns along the way, these efforts helped us reach hundreds of providers, including those in those areas with the most need. And finally, to the right, you will see that WPS in year 3 created positions, some new, to provide dedicated staff to help us reach our goals. We welcomed Pragati Singh, a population health specialist, and Joelle, our full-time contractor medical director that was dedicated to this project. And finally, Ellen Barra and I spent many hours dedicated to the challenges. And for Ellen, it was actually 60% of her hours worked that she committed to the chronic care management learning. And for me, in depression screening, it was 40%. So you've probably all heard it before, but we can tell you that based on our experience, teamwork really does make the dream work. Back to you, Joelle.
Thanks, Mary. So when I came on board, as Mary mentioned, the depression screening project had already been going on for a couple of years. I think one of the most exciting parts of the design of this project was, this is going to sound very narcissistic, but was the fact that I got to come on as a full-time medical director. And then we also had our population health specialist, Pragati Singh, join. And we were there expressly for the project. Now, we were also kind of outsiders because we didn't know how it had been done before. And, this had two advantages. One, since we were devoted to the project, that's all we had to think about. But then we were able to sort of maintain this um, tension. So there was some advantage and some disadvantage to having us be brand new. But we had this incredible team who was willing to put up with that occasional discomfort that, brand new people can produce. But it really worked. I think there was a lot of back and forth between us and the team that just fueled this creativity and this forward movement. So let me tell you a little bit about some of the design changes and some of our pivot points. Well, one of the most beloved parts of the plan design, which we were excited about, was our roadshow. We had planned to have standalone conferences where we would have a few hours of education and outreach, and we asked that people come to us. Well, we live in a virtual world now, and things had changed. People weren't necessarily signing up to come out to, I know it's hard to believe, St. Louis in January and Detroit in the winter. What we discovered, however, is that we could actually do a lot of good by offering content to other conferences that were happening. This allowed us to get to a wide range of audiences, a wide range of professions, and actually proved to be really worthwhile. Well, when we were out and about, giving our education, one of the things that we really committed to doing for all of us was to listen. We wanted our offerings to be a bi-directional conversation. We wanted people to tell us how they had conceived of some of these programs and done it well. We also didn't shy away from using digital media. We have a lot of content now on our YouTube channel, and that also helped us really meet needs of those we were hoping to reach. So we're recording this session, and there's a reason for that. While we appreciate everyone who's with us live, we know that it's not always convenient, and we appreciate that, and we tried to accommodate that. The other thing we did was reach out to external partners. Now, this is something that POA does really well, and we followed their lead. But we did things perhaps a little bit differently. We invited folks to be part of our WPS Physician Roundtable discussions where we talk specifically about these programs, about the barriers that might be in play, how we were able to break through those barriers, and talk about challenges that still remained. We also began to form partnership with folks that we thought of as non-traditional, not just physician practices, not just hospital-based practices, but also folks who did things like the mobile integrated health unit. We had a wonderful partnership with some of our folks in St. Louis in Washington County who are doing incredible work with their mobile integrated health units. The podcasts, we were hoping to have our own podcast, but again, what we discovered is that aligning ourselves with other partners and offering content worked out pretty well. Our picture here is Pragati Singh on the left and myself on the right. And we're very excited because we're about to record for StoryCorps, something that was on my bucket list, and big fans of the show. And we were able to sit in the booth and record our stories. And what we recorded was how we ended up doing the project in the first place and what attracted us about working in the health equity landscape. The other thing we conceived of at the beginning were postcards. Could we, in addition to the comparative billing report, send out postcards to those physicians and practices with low utilization of depression screening and chronic care management? Ultimately, though, what we realized is that both of those programs have such a low utilization that that wasn't going to really impact a lot of beneficiaries. Instead, we actually were able to develop a dashboard thanks to Pragati and her team, and we targeted instead those with high beneficiary counts, hoping to increase their use and ultimately get to more beneficiaries. We also thought about using internal resources, including our own marketing department. And Mary, if you don't mind going to the next slide, I'll tell you what I'm talking about. So our marketing department got wind of the project, and they were tremendous partners with us. We used resources we already had, and they helped us design and explain our goals on a actual one pager, we would call it. We could give this out both electronically and with real paper when we went out to conferences. It explained the program itself and the project, and then also introduce them to partners. We felt that even in the digital age, even with virtual space, we wanted people to connect to us as people, as professionals, so that they could see that there were, real, in fact, human beings behind this effort. Several of the folks on the one page are here tonight, including Mary, who you heard from already, Ellen Vera from our Provider Outreach and Education team is here. Matt Davis you'll hear from as well. Prakati Singh, I saw her sign on. And Abby Wolf, also from our Insight team, although she couldn't be here tonight, she was certainly absolutely essential in providing some of the data we're going to show you tonight. So let's get to it. Our next slide, Mary. What were our goals for our first project, our depression screening? I know these look fairly modest, but I want to give you some context. So absolutely, we wanted to increase the use of depression screening by 5%. We wanted to increase the use of depression screening by 2.5% in areas with an area deprivation index, or an ADI, greater than the 70th percentile. And we wanted to decrease suicide attempt claims by 5%. What makes this so incredible is that those were the same goals that we'd had the prior 2 years. And a lot of us thought, oh my gosh, are we going to be able to hit these because they've done such a great job. Dr. Robert Kettler, our wonderful medical director, had helped steward this over the last couple of years. They had made such great strides, really done a high level of impact. We wondered if we were going to be able to do the same. Next slide. And the reason that we were so keen is because there's a real disconnect between what goes on the right slide in terms of the prevalence of depression by state, greater than 10%, which is more than the average. But yet our screening state by state was quite low in 2021, and we knew we could do better. Next slide. So how did we do this? I again want to give a huge shout out to my colleagues in provider outreach and education, especially Mary. It can't be easy to muster enthusiasm for a program that you've led and participated in over the last couple of years for a third year, but they certainly did. The team produced 5 hours of content, and during the project year had over 600 views just on in the virtual space. Next slide. And their outreach continued with 40 hours of live sessions, and between J5 and J8, over 1,700 attendees that they touched throughout the project year. It was just an incredible effort, and they never faltered. I was just amazed at what they were able to manage. We did a lot together. We had a great time doing it, but still just incredible effort. Next slide, Mary. So When all was said and done, what did we achieve? Well, I can tell you that in J5, jurisdiction 5, over 34,000 beneficiaries were screened for depression during the project year, and over 450 new providers provided depression screening to their patients. In J8, again, 34,000 beneficiaries screened for depression, and over 700 providers provided depression screening to their patients for the first time. It's pretty exciting. So let's take a look at what we reported to CMS this year. So one of the nice things about being able to talk to you now is that our claims have had time to adjudicate. And we can tell you that our goal of 5% was not only achieved, but fairly handedly. We had a 35% increase in depression screening claims for all beneficiaries when compared to the preceding 12 months, which is just amazing and really reflects the effort of the team and our partners. Next slide. You know, we were not sure that we were going to know how to do areas of high ADI. Could we reach those for whom the social drivers of health were a factor? We looked at those with a ADI percentile greater than 70, and indeed, we were able to see an increase of 26% of depression screening compared to the prior year. And also, we also noticed a significant increase among our rural beneficiaries in this jurisdiction of about 52%, and our dual eligible beneficiaries, that is those who are eligible for both Medicare and Medicaid, and 6% in J5 when compared to the prior year, which is really just outstanding. Next slide. So here's where my team and I really feel that things were especially important. So we wanted to demonstrate fewer suicide attempt claims. And we did. It's an 11% decrease from 2021, but 67 claims smaller than we might expect for this same period of performance. Those are people. Those are people that are providers because they did depression screening impacted. We don't know which ones, but we know that they did outstanding work. Next slide. And then just summarizes it all together for our key performance indicators. Now these are compared to our initial program year, not our last preceding 12 months, but over 3 years, we were able to increase depression screening claims 37%, and importantly, reduce suicide attempt claims by 9%. And that got us where we needed to be with our goals. Even in an area where we weren't sure, we knew exactly how to achieve it. We did manage in our disadvantaged beneficiaries. And we'll talk next about our folks in compared to other MACs. Next slide. Because this is really important, and I believe that our own contractor medical director, Dr. Jill Sumfest, as well as members of our CAC, suggested to us that we take a look at how we were doing compared to other MACs. After all, you know, it's a new age. Maybe everyone's screening more for depression. Well, indeed, even when we compared to other MACs, we still did pretty well. So all other jurisdictions had an increase in claims of 5%. In areas of high ADI, we did 41.7%. And then our overall claims in J5 went up over 100% compared to our other contracts. Next slide. And then also important, are we stewarding Medicare dollars? And indeed, it appears that we are. It appears that we are able to demonstrate some pretty significant improvements in terms of amount paid for beneficiary. These are negatives, meaning that a greater number is better. So by year 3, we indeed had achieved improved status. We're not sure exactly how that works yet, but we know that there's a correlation. And then importantly, compared to other jurisdictions, we had improved our change in suicide claims. We know that that's an imperfect measure too, but it did give us an opportunity to demonstrate whether or not we had made our impact. All right, let's take a look at jurisdiction 8. So did we do what we said we were going to do? Well, compared to prior year, we increased our depression screening claims by 41% during that year. 5% was our goal, 41% was where we ended up. You'll see a little dip in January. That's pretty typical for our Medicare beneficiaries whose deductible year starts then. Next slide. How do we do for our areas of high area deprivation indices? It appears that we did rather well, actually. We got a 31% increase in depression screening for those folks. Next slide. And our suicide attempt claims. So this is perhaps our area of weakest performance indicator. And I'll show you on the next slide. We were hoping to get a 5% decrease. We got a 3% decrease. But again, I looked at the numbers, and that's 31 fewer suicide attempt claims than we would have predicted without the project. So although we can be slightly disappointed by those results, we know we're still having an impact. And let's look over the whole life of the project in the next slide. So compared to other MACs, we indeed have done a fairly good job compared to other contracts. You can see we're definitely performing, especially in overall claims, but definitely even in our areas of high ADI. Next slide. And then you can see also here in terms of our opportunities to steward Medicare dollars, we're doing a great job. And our percent change in suicide claims is better than other MACs. And I'm going to hand it over to our colleague from Insight, Matt Davis, to talk a little bit more about stewarding those Medicare dollars for both jurisdictions.
Thanks, Dr. Vlahakis. As Dr. Vlahakis just referred to, in both J5 and J8, we analyzed patterns in paid claims for the beneficiaries who received treatment for depression diagnoses on a 3-year time period after the identification, the diagnosis, and the treatment. In J5, we identified around a $380 per beneficiary cost savings. Again, that's for each beneficiary who received the depression diagnosis and subsequent treatment. And in jurisdiction 8, that value was almost $2,000 per beneficiary. So based on this return on investment and the additional beneficiaries who are now receiving depression screening services across both of our jurisdictions through this period of performance, we estimated Medicare trust fund savings of upwards of $50 million that they could expect over the course of the next 3 years. And this value continues to increase with each and every additional proactive depression catch by you, the provider community. Next slide, please. So none of the impressive results that we've talked about here with depression screening would be possible without the amazing partnerships that we realized with you, the provider community. While we recognize the increased use of depression screening was incorporated into the practice of many of you across both of our jurisdictions, and so we wanted to take this time to highlight a specific subset of providers who really bought into our program and incorporated this into their practices and provided this depression screening service to a large proportion of the Medicare beneficiaries that they provide care to. So again, just wanted to thank each and every one of you who have partnered with us in this program and helped us realize these results along the way of our depression screening program. Next slide. And I'm going to turn it over to Ellen.
Okay, thank you, Matt. Well, what we're going to talk about here just for a second is chronic care management. As Dr. Vlahakis had talked about, chronic care management was the newer project within this Innovation Challenge. And chronic care management is really a holistic approach to patient care. It utilizes not only the physician or practitioner, but also really takes advantage of the clinical staff to provide great care to the patient. So chronic care management is a monthly service payable by Medicare when, of course, all of the requirements are met. And the use of the clinical staff really allows for an increased trust relationship between that patient and that practitioner office. That clinical staff, by making those monthly or even sometimes weekly contacts with that patient, really shows the empathy and the concern for that patient's health by that practitioner office. This increased trust relationship then allows for the patient to really kind of pay more attention to their health. They're being given advice by that clinical staff. When that advice is given, the clinical staff is following up on that. And so it really makes for a better exchange of information rather than a 5 or 10 minute meeting with the physician themselves. It also allows for the patient to share more timely any issues or concerns that they may have. By doing so, problems then may be addressed before they result in a hospitalization, an emergency room service, or a more urgently needed care or encounter, face-to-face encounter with that provider. So the goal of the use of CCM is allowing for fewer ER visits, fewer inpatient hospital care. And one of the things that we stressed in our education, that although chronic care management does have patient sharing, which means that they do have to pay the copayment, the cost of the deductible for just one hospital stay will pay for almost 5 years of monthly chronic care management services. So as part of chronic care management, you develop a care plan. So it identifies where the patient is at now, where you want that patient to be. You really look at medication management. As I'm sure we're all aware, beneficiaries who are on Medicare are either on Medicare through age, they're over age 65, or through disability. And they're seeing a lot of different providers who are prescribing a lot of different medications. Well, CCM then, part of that is really looking in depth at all of those medications. Are they working? Are they not, et cetera. It identifies the other resources, and this could be other practitioners or providers who are part of that patient care, and then also community resources. The local YMCA, church organizations, other things within the community that can help promote that patient's health. There's requirements for periodic review and revision, and that's that conversation with that clinical staff and then the practitioner. So this is really kind of chronic care management in a nutshell. We do have multiple, and we really do mean multiple, YouTube videos available on our YouTube channel, and I did place that into the chat for you. So Joelle, I'll turn it back over to you.
Thanks, Ellen. So what were our ultimate goals for chronic care management? It's a bigger program. It was new to us. We thought we could increase chronic care management services by 5%. We hope to increase the use of chronic care management by 2.5% in areas where health disparities might be highest. And then ultimately, we were hoping to diminish the use of emergency department services by 1% for all Medicare beneficiaries in our jurisdiction. And we know that a lot of our Medicare beneficiaries live with 2 or more chronic conditions. But fewer than 1% actually have utilized chronic care management services in the past. So we had a ways to go. How do we do it? Next slide. So this is what Ellen would probably be too modest to tell you, but these were our live webinars. We had over 45 hours of continuing education produced, and over the course of the project year, over 2,500 attendees to our live sessions. Next slide. And then we produced 22 sessions for our chronic care management playlist, and those during the project year have had over 6,000 views. We only measured during the project year. They've since had considerably more. And that, again, is really speaks to the dedication of our provider outreach and education community. Next slide. All right, so how do we do? Let's take a look here. We're going to look at J5 first. We were able to indeed increase chronic care management claims for our jurisdiction 5 by 18% when compared to the preceding 12 months. You'll see that our goal was around 211,000 CCM claims. We got upwards of 250,000 claims. One of the other things I'll just point out of interest is you can see where we really hit our stride. That upwards momentum really started to put us in good stead by the time we hit around April. We kind of wish we could do the project for longer because we know we could do even more. We were finally starting to get the hang of it. And next slide, please. And that includes, and probably especially for our areas of high area deprivation, we were learning right alongside everyone else how to do this and how to do this well. And you've heard us talk a lot about our bi-directional communication when we did conferences and the like, and especially our physician roundtables. We learned a lot, and we had to really go where folks knew what it was like to practice in areas of low utilization and areas where there might be social drivers of health. Next slide. So did we do it in terms of the Medicare Trust Fund? We were hoping to get a 1% diminishment of emergency room visits during the project year. We had a 7% increase, or rather, a 6% decrease in emergency department visits for our beneficiaries with multiple conditions when compared to the preceding 12 months. So we felt pretty good about that. Next slide. Just in summary, what it looks like compared to the preceding years, we were able to increase our chronic care management claims, increase those claims also for our more disadvantaged beneficiaries, and ultimately also reduce our emergency department visit claims. How do we do compared to other MACs? Let's take a look. So other jurisdictions were indeed also trying to improve their use of chronic care management. We all know it's good for patients, but we were able to increase it by a far greater number. And again, I think we had started getting the hang of things during our project year. We were putting a lot of emphasis on what it could do, not only for our patients, but also for provider practices, because we were learning as we went about that. Next slide. And then I think this also helps you to understand how powerful chronic care management can be for our beneficiaries. Not only does it lower emergency department visits, but the amount that needs to be spent per beneficiary during the project year is less. And that we believe that's in part because we're managing crises. They're more connected to their provider and their provider staff, and we know ultimately it's a better experience for all. All right, next slide. So in J8, how did we do? Well, our folks in Michigan and Indiana really helped us a lot. They were active partners in chronic care management, very eager to learn, and you can see the results of that. Our goals were perhaps a little modest. We did very well in J8 when it came to chronic care management, improving almost by an order of magnitude more than we thought. And I want to point out, too, that when claims adjudicate for chronic care management over 90 days, it's also an opportunity for emergency department claims to adjudicate during that time. So we would expect those to rise, and they did slightly, but not to the degree that we expected. Next slide. Again, you can see just by the curve that we started to understand how powerful this could be and how to encourage our providers to use this program as we got towards the spring of the project year. Overall, we had established a goal of 5%, and we had an increase of 33% during this project year. Next slide. How do we do for our beneficiaries with high ADIs or area deprivation indices? We did very well, actually. We were able to demonstrate that we could enhance the care of our disadvantaged beneficiaries by getting an increase of 21% in our CCM claims, which was beyond what we were hoping for and just absolutely thrilled us. So how do we do on those emergency room visits? As you know, we were hoping for a 1% diminishment, and we had upwards of an 8% reduction in emergency department visits for beneficiaries with multiple conditions when compared to the prior 12 months. How did we do compared to other MACs? Always good to see. Everyone else was also trying to enhance their use of the programs, but we outdistanced most of the other jurisdictions. Next slide. And then our amount paid per beneficiary also. It showed that not only were folks perhaps getting an enhanced level of care, but it was also at lower cost and more efficient. Next slide. All right, I'm going to hand it over to Matt. Once again.
Thanks, Dr. Vlahakis. Just as we talked about in depression screening, we also perform the same return on investment analysis for our chronic care management program, this time analyzing Medicare claim utilization for beneficiaries who received chronic care management compared to those who did not 2 years after receiving that care. And likewise, as what we talked about in depression screening, we identified a cost savings to the Medicare program for each beneficiary who receives chronic care management services to the tune of over $4,000 per beneficiary in jurisdiction 5 and almost $3,000 per beneficiary in jurisdiction 8. Now, this, we estimate, is over a 2-year period, should lead Medicare to realize an estimated trust fund savings of upwards of $20 million. But again, every single additional beneficiary who receives chronic care management care plans only adds to that cost savings to the Medicare trust fund. Next slide, please. And again, just like with depression screening, all those great results that Dr. Vlahakis just talked about wouldn't be possible without the partnerships of our provider community. And so similarly to depression screening, while everyone did a great job buying in, and we very much appreciate your partnership in implementation of our program and partnering with us in that, we wanted to shout out a set of specific providers who significantly increased their utilization of these important care plans for their beneficiary population that they provide care to on a daily basis. And so again, we wanted to thank each and every one of you and again, highlight some particularly important increased use among our provider community here in jurisdictions 5 and 8. And I'm going to pass it now back to Dr. Vlahakis.
So when I looked back on our project year, trying to figure out, how did we manage to do this? I think there were some key components that allowed us to not only perform and ultimately demonstrate achievement of our key performance indicators, but also we really just had a wonderful year learning. So of course, some of that was innovation. We were, I believe, a high-performing team. We were encouraged to explore every opportunity We were allowed to fail, but then encouraged to pivot and innovate. And that was very much thanks to the strong support from our WPS leadership. I can't stress that enough. They really allowed us to incubate ideas and try things. They also encouraged us to investigate on our own. A lot of us took some courses. We learned as much as possible about real life challenges for providers and beneficiaries who could benefit from the programs. We were especially keen to learn how they were achieving those goals related to our health equity space. We looked for and sought out and nurtured new partnerships, even those non-traditional ones where at first we weren't sure how we were going to collaborate. We all kept talking till we figured it out. And we just met some extraordinary professionals, and I would say also really incredible humans who are out there doing the good work, fighting the good fight, and showing us how to do it. We hoped that we could be a hub. We could collect some of these wonderful ideas and then help disperse them such that we could cross-pollinate throughout, between communities even. We also really valued the conversations that we had. We wanted to learn right alongside everyone else, especially our partners and our stakeholders. We educated ourselves. We attended conferences. I participated in the AMA series on achieving health equity. We shared what we learned, hopefully in high-value education developed by our entire project team. It wasn't unusual for the provider outreach and education team, myself, for our really extraordinary and brilliant population specialist, Pragati Singh, to work with us and figure out what we could do that was different. We tried to individualize these educational outreach opportunities by giving individualized claims data. We also sought out local resources and embedded them within our presentation to try to make them relevant to the audience. And then we listened and learned. We took a lot of really tough questions. We didn't always have the answers, but we tried very hard to follow through and get back to people. And then we developed new tools as best as we could. We have a sophisticated dashboard now, thanks to Pragati and her team, to direct our efforts towards those providers with high beneficiary counts. Next slide. And I can't say enough about how much fun we had with our WPS physician roundtables. We've listed a few of our participants, particularly some of you from our CAC. We really, really appreciated the things that you offered, the candor with which you brought forth some of your challenges, and your willingness to help lead us to better always. Next slide. Okay, so this would be no fun without our imaginations, and one of the things we often talked about is if we had more time, what else would we want to do? What else could we do if we imagine things? Next slide. So we would love to do more WPS physician roundtables. We just found them to be incredibly valuable. We would love to do them themed, so have folks who know what it's like to administer them, what it's like, as one of our partners said, to get over the hump when you implement, for example, a chronic care management plan. I'd love to keep writing our Medicare Buzz blog, which has been incredibly fun and a joint effort with the team. I'd love to write about making the case for chronic care management. I'd love to write a little bit more about how to partner with patients and families when levels of health literacy are different from the office team. That came up again and again. One of the things we'd love to keep exploring is machine learning models. That's one of the things we had and hoped to achieve in our short project year, and we're very close to achieving that, but we'd love to invest a little more time and effort doing that. We'd love to get sophisticated with both of these programs and explore that incredibly strong relationship between depression and chronic illness. One leads to the other, and there's certainly a bidirectionality and a relationship there that we think is worth trying to dig into. Could we develop our own models such that we would know how much better someone's chronic illness or diabetes might get if we treated their depression adequately? And another thing that we discovered while we were working is that, we have these large jurisdictions and it's great, but many of our public health departments, they are working with single disease targets. If we chose single disease targets, could we be better partners with public health departments such that our education could more closely line up with that? We don't know. We'd like to explore that a little more. I think it would be a fun way to keep doing the project. Next slide. All right, so a little bit about health equity. You know, it was an interesting year. I learned a lot, and probably one of the most impactful time for me was actually when I was lucky enough to attend the first ever health equity conference that was hosted by CMS and attended by a variety of public figures. We aimed for 2.5% of improvement for our depression screening and our chronic care management in those populations that might be affected by the social drivers of health. It's really interesting, right? Because I think we did that. We aimed that way because we thought we didn't want to get ahead of ourselves. We didn't know what we didn't know yet. But if we're going to be bold about this, let's think. If we're trying to achieve health equity, don't we need to work harder in those spaces? So I would put forth that the next time, if I were to do this again, I would try to achieve even greater gains in those areas compared to our general claimants, and just see, could we do it? I feel like we're just getting started. I feel like we learned so much this project year. The generative nature of the team, we were able to develop more ideas. We have even more we'd love to try. We are also going to continue to march along and keep tabs on our numbers and our claims this year as well, just to see if we're able to continue to have this honeymoon period where after the project's over, that the work stands alone. We talk a lot about the triple aim in medicine, and a lot of you know what that is. It's kind of that sweet spot where we try to manage to get quality of care to be improved, that cost of care to go down, and the patient experience of the care to also be improved. The quadruple aim is where we add all of that plus the physician experience of delivering that care. Does the provider feel good? And I know in cases of chronic care management, they certainly do. The quintuple aim, that's what I learned this year. In fact, I kind of came to this on my own and then discovered it was my idea. It's been around for a while, but adding all of these opportunities for high quality, patient-centered, cost-effective care that doesn't burn out our providers, but delivering that care to everyone, regardless of where they live, what their zip code is, or the kinds of challenges that they face. Next slide. I want to thank each and every one of you. I know I can see who's attending, and each of you has played a role in improving our efforts, whether you were part of our advisory group to our provider outreach and education team, or you've played a role in our CAC committee. I just really, you've given us a lot of energy, support, ideas, and we can't thank you and our other partners enough. And for those of you who are joining via the virtual space and listening to me later, please know that your efforts didn't go unnoticed, and we learned from each and every one of you. And with that, I'm going to open it up to thoughts and questions. I know you can submit them through the chat function for sure, and that works for some of us who are a little shy. I'm also going to point you to our last two slides, which we can send to you. There are some online resources. These links are live, and they will get you to our chronic care management playlist and our depression screening playlist, our blog, and some other really great, wonderful resources. I put together some further reading for you on the next slide, a bibliography of sorts, but just for those of you who are thoughtful and want to read a little bit more. Those are some of the small collection of readings that we did to guide our work and help us produce some education. So I'll let our team lead. I appreciate everyone's attention. It's a very full hour, I know. We hoped we could get it in under 60 minutes. I think we have, but if those of you who are still attending have any stamina at all and you'd like to put forth your questions, the team of us, we're all here, including our population health specialist, and I know we'd love to entertain any of the thoughts that you might have and challenges to our data and other things.
Well, I'm not seeing anything in the chat at this time.
I wondered if any of the participants wanted to talk a little bit about their own experiences with either of these programs, challenges, things that you found to be helpful as you tried to develop these for your patients. And Dr. Estelle is wondering if we can unmute him. Is that possible?
I'm trying to work on that right now. Hang on a second. Okay, Dr. Estelle, you are unmuted on our side.
Can you hear me?
Yes, we can.
Yeah.
Okay. So I got a number of comments. First of all, it was a wonderful presentation. I made notes throughout this, and I said win-win. It's not a win-win. Your quadruple is a much better description of what happened. So the depression is much. I've got my computer going, talking at the same time. I apologize. Anyway, the depression screen, the big problem with that is we have 10 providers meet every Friday, and the problem is getting them to they think they need to address the depression in depth. They really don't. They need to screen it, and they can address it that day with an evaluation and management visit or schedule one. But they think they have to address it all at the same time. If you can define that, would be better. The second is chronic care management. 10 years ago, we had a lot of success with it. At this point, I've tried hard and not had much success. The problem is, the difference is, number one, my people were doing the calls. They were seeing the patient in the office, and they trusted them. Now it's a centralized person calling. I'm not sure how you all can improve that. You probably cannot. The second thing with that is everybody gets lots of calls from people that are trying to sell insurance, sell this, that, and so nobody answers their phone calls anymore. Anyway, any questions?
I wonder if, Ellen, you want to talk about the chronic care management piece and some of the folks that we've talked to about, the centralized versus office-specific chronic care management, and then also speak a little bit to how some of our folks have gotten through the folks not answering their phone.
Yeah, there's a couple of ways that provider offices can actually provide chronic care management. One is through the use of their own clinical staff, and then the other is through the use of contracted staff, whether that's a chronic care management organization, whether it's the use of EMTs or community health workers, et cetera, within your organization, within your community itself. And so as you're developing that plan, as you're having that conversation with the patient about chronic care management, then you introduce those people. You say it, hi, I'm Ellen, I'm from Dr. So-and-so's office, and I'm going to be the one contacting you, and we're going to make arrangements to contact you on Tuesday morning at 9 o'clock. And here's the number I'm going to be calling from, that type of thing. So you kind of address those things when you're having the conversation with that patient about chronic care management service itself. If the patient knows that you're getting ready to call, then they're waiting for that call. It's it's an appointment for them. Hopefully, they're waiting there for your call. Did that answer your questions, Dr. Estelle?
That helps tremendously. We work for Baptist Hospital System, so they put a nurse in our office, and we introduce her to her. But it would be great if we would. Your suggestion's wonderful. Say, Kim's going to be calling you back at 9 o'clock on Monday with this number. That's going to work much better. Excellent idea.
Okay. Anything else from anyone?
Mary, do you want to comment at all about the depression screening? I know you and I have talked a lot about that.
Well, I think at best is just to make certain that the staff recognizes that it is depression screening, and that the determination of whether to move forward is exactly that. There's screening, and then if there's positive results, then of course you would want to schedule the evaluation and management. And like you said, it can be done that day, or the patient can come back later. But I think it's all about the education and pointing out that this indeed is a screening and it is a billable service.
It's not just the staff, it's the physicians, the nurse practitioners. We have 3 nurse practitioners, 7 physicians. I'm there every week trying to educate them. And they have this fear, if they bring it up, they're stuck with the patient for 45 minutes.
Yeah, and I think that is, speaks to, as a provider myself, we're all very compulsive. We all want to really, we want to do a great job. But I think, I'm sure you role model, which is really key. And then also, getting our colleagues to trust one another, to trust the process, to trust the resources that we might use. One of the things that chronic care management does so well is to collectivize a group of resources outside of the office so that care can continue beyond the walls of the clinic or office setting. I think that can be really helpful if we take a page out of that for depression screening also, where we have resources and the like. And we've talked a little bit about this, I think, Dr. Estelle, you and I have about, bereavement services with the local hospice, for example. There are ways in which you can make sure your patients get what you need, and you're not all of it. It's not one-stop shopping. And then you don't feel like you have to solve every problem all the time. And then I think, just letting them have the experience of watching what happens when they do it differently, and they don't necessarily have to tackle it on one day, and getting folks to feel confident about that, and, being able to distinguish between a patient who might be at risk for harming themselves, which we don't want, obviously. We need to screen for that, and the depression screening does that, and someone who might simply need something to improve their quality of life, whether that be cognitive behavioral therapy or medications. But again, I think that takes a while to figure out, and it takes a little bit of time to develop confidence in it. We've heard from other providers who are even, more overwhelmed by it, and they're said, well, what do I do with a positive? Well, there are really high quality educational pieces out there from the American College of Physicians and the American Association of Family Physicians that you can get CME for. And that's another place to go. I know I had to educate myself quite a bit with this project. I wanted to make sure I knew all that there was out there. And some of the things are just take a few minutes. And there's a little reading and a quiz afterwards, and you do feel like you've got a better handle on it. So I can send those things to you if you like, but I've found them to be particularly helpful.
And you are correct. I have physicians, nurse practitioners coming all the time, advice how to deal with this. I'm right there for 10 of us, but the whole big state, how do you improve it?
And I think that's the secret sauce, isn't it? And you've heard me say this, and my team believes it also. We know that, this claims data is rich and it's wonderful, and it's great to take a step back from it and say, hey, look at this. But it really happens in that one-on-one interaction, that sacred space, I like to call it, between the patient and the provider. And that's something that, we don't want to prescribe. We don't want to make it the same. We know it's unique, and each of those encounters is unique, and we want to foster that relational uh, interaction. That's essential to all this. So I don't know, it's so hard to know if you can teach that, but I'm quite sure that your patients are in excellent hands, Dr. Estelle, because I know you've got pretty amazing relational skills there.
Thank you very much. Appreciate it.
We're open for more comments. You can enter it in the chat. We can unmute you. Happy to do that.
And at this time, I'm not seeing anything else in the chat.
Well, I would say the whole reason for us to present this was to give you all a big thank you for everything that you've done to help with the project, to teach us what we needed to do to be successful. And if I can gift back to you sometime, I'd love to do that. I'd like to thank you for your attendance, and then also thank those who are bothering to access this in our recorded session. For your time as well and your partnership. And please reach out to us. We'd love to hear your success stories, and by all means. Any other comments from my fellow presenters?
I don't have any, Dr. Valhakis.
Neither do I, but thanks everyone for your efforts.
Yeah, thank you. And I know Pragati is on the line, and I'd like to have a special shout out to her for all the work she did during the project year and for being with us tonight. Thank you. All right, everyone, have a wonderful evening, and thank you so much for your time.
And then this concludes our presentation for today. Thanks, guys. Have a great evening.